Hello, in this video we will discuss about hypertriglyceridemia. A common symptom that is related with hypertriglyceridemia is usually racing heart, loss of appetite, abdominal pain, back pain, and feeling bloated. People with these symptoms may have signs of hypertriglyceridemia and must seek medical attention immediately. To evaluate the quantity of fat in the blood, a doctor will typically take blood for a blood test called triglyceride test. After the blood test result is received, normal people have less than 150 mg/dl. If the person is suspected with hypertriglyceridemia, the results may appear higher than normal range value. Hypertriglyceridemia. Hyper means high, emia refer to blood levels, and triglycerides are the most abundant fatty molecules in the body. Therefore, hypertriglyceridemia is when there are excess triglycerides in the blood. Excessive triglycerides accumulate in the body, and depending on where the accumulation occurs, it may cause complications such as atherosclerosis and acute pancreatitis. Atherosclerosis can occur in the pathway that involve endothelial dysfunction. This dysfunction allows the small triglycerides remnant to reach the intimal layers where it will be taken out by macrophage, leading to the formation of foam cells. The foam cells will promote the fatty streaks formation, which is the precursor to the atherosclerotic plaque. Meanwhile, acute pancreatitis occurs due to the high concentrations of large chylomicrons in the blood, which can obstruct the capillaries, leading to ischemia of the pancreas. Hypertriglyceridemia, commonly classified as either primary or secondary hypertriglyceridemia. Secondary causes are more common as it may be associated with obesity, diabetes mellitus, high carbohydrate intake, hypothyroidism, and increase in alcohol intake. Secondary hypertriglyceridemia. The more common cause of secondary hypertriglyceridemia is obesity, diabetes mellitus, and high carbohydrate diets. With obesity, there is hepatic overproduction of VLDL and decreased circulating triglyceride breakdown. Next is diabetes mellitus. Both type 1 and type 2 is associated with ineffective or less effective than normal lipoprotein lipase. Lipoprotein lipase is important as it is the primary enzyme for triglyceride breakdown and release of fatty acids in the circulation. The reduction can lead to high levels of these lipids, while in high carbohydrate diets, the carbohydrate will make up more than 60% of total calorie intake, which will lead to increase in carbohydrate diets breakdown and increased production of free fatty acids. This consequence can be used to synthesize more triglycerides, therefore causing hypertriglyceridemia through different mechanisms such as hypothyroidism, increase in alcohol intake, and drugs. In hypothyroidism, the triglycerides are elevated due to the reduce in hepatic lipase activity, which will slow the catabolism of very low-density lipoprotein remnants. Next, excessive alcohol intake can cause hypertriglyceridemia because the alcohol can impair lipid breakdown, which will increase the levels of plasma VLDL with or without hyperchylomicronemia. Finally, several drugs such as glycocorticoids, beta blockers, and thiazide diuric can also cause hypertriglyceridemia. Primary hypertriglyceridemia. Primary or familial hypertriglyceridemia usually occur due to genetic causes such as apolipoprotein gene mutation. Familial hypertriglyceridemia is included in familial dysplasia, which consists of type 1, type 2, type 3, and type 4. Only type 1, 3, and 4 will lead to hypertriglyceridemia. Type 1 is called familial hyperchylomicronemia, which can be defined as high levels of chylomicrons in circulation. This is caused by autosomal recessive mutation and can lead to severely reduced or absent lipoprotein lipase enzyme activity. Meanwhile, type 3 is known as familial dysbeta lipoproteinemia. This occurs when chylomicrons remnants cannot be removed by the liver. The clearance of remnants is done with the help of apolipoprotein E, as mostly they are the defects related to apolipoprotein E or its receptor, which will lead to hypertriglyceridemia. Lastly, type 4 or familial hypertriglyceridemia involve autosomal dominant mutation of lipoprotein lipase genes. In this case, there is an increase of hepatic synthesis of VLDL and decrease in the removal of VLDL, resulting in hypertriglyceridemia. Suggested treatment for hypertriglyceridemia are controlled diet, exercise, alcohol reduction, and medication such as fibrates, niacin, and omega-3 fatty acids, which must be taken when levels of triglyceride is more than 886 mgdl.